Good afternoon. My name is Supreet Clare. I'm an addiction medicine research fellow with the British Columbia Center on Substance Use. I'm here to present on behalf of myself and my colleagues on a project entitled Take-Home Drug Checking as a Novel Harm Reduction Strategy in British Columbia, Canada. With regards to conflicts of interest, I'm currently completing a research fellowship which is funded by a NIDA grant, and I'm part of the Research in Addiction Medicine Scholars Program, which is funded by another NIDA grant. This is a situation that's likely familiar for many of those in the audience, since it is such a widespread concern. But in British Columbia, which is the westernmost province in Canada, we're in the midst of a large and growing public health emergency due to the rising number of illicit opioid overdose deaths. The majority of these deaths from surveillance data we know occur in private residences, which is concerning. One of the primary drivers in our jurisdiction of this rising mortality rate is that the drug supply in our province is heavily contaminated with fentanyl and other synthetic opioids. Opioids, such as heroin or colloquially known as down, have a fentanyl positivity rate of approximately 90%. Based on surveillance data, and stimulants such as crystal methamphetamine and cocaine also are regularly contaminated with fentanyl at a rate of approximately 3%, which is concerning given the differences in class effect. We're lucky in British Columbia that we also have access to numerous harm reduction services, including widespread naloxone kit distribution, access to clean drug use supplies, and numerous supervised consumption sites, which often act as hubs to provide other harm reduction services. A more recent harm reduction service that's emerged is the availability of drug checking. So individuals can present to these sites and have their substances tested for the presence of potential adulterants. Drug checking as a class is using, looking at the chemical analysis of a substance to identify components. Typically, these drug checking services either use immunoassay test strips, such as fentanyl test strips, or there's also access to more sophisticated technologies such as spectrometer, which isn't as instantaneous in terms of its ability to provide information. We know from previous research that there is an interest in knowing about fentanyl contamination amongst people who use drugs, and that there is planned behavior change if fentanyl is detected in tested substance. So there is potential utility in this as a harm reduction intervention. We also know that fentanyl test strips are widely available for purchase and personal use. However, the accuracy of fentanyl test strips in this take-home setting has not been evaluated, which is what our program is set up to do. So here in British Columbia, 10 sites that were already offering harm reduction services, including on-site drug checking, where individuals can go in and have a technician test their substances. There was a 3-month pilot where we initiated take-home drug checking. So participants who wanted to have their substances tested were offered a drug checking kit containing 5 fentanyl test strips, instructions, which you'll see on the right, a survey to complete, and specifically the survey had some questions around behavior change, but most importantly, the survey was used to collect information about what substance was tested, so what the participant believed the substance to be, or what class they believed it to be in, and then the result of the fentanyl test strip, whether there was fentanyl or not in that substance. So we were essentially creating an intervention group where we were trying to see when individuals are using these fentanyl test strips at home, what the fentanyl positivity of various substance groups was. So again, our primary outcome for this study was to determine the accuracy of take-home drug checking. So in the hands of participants instead of technicians, what is the accuracy? Specifically with regards to the fentanyl positivity of opioid samples that were tested using take-home drug checking compared to the fentanyl positivity of opioid samples that were tested by technicians using on-site drug checking. In terms of statistical analysis, we used a 2 one-sided test approach with a predefined equivalence limit of 5%. And some of our secondary outcomes for this pilot program will look at acceptability as well as behavior change associated with a positive result. We received 336 return surveys in this 3-month pilot, which produced a total of 1,680 fentanyl test results. Because individuals were allowed to have more than one survey or complete more than one survey over the period of the pilot, we had 218 unique individuals. You can see the demographics there on the right. So they're predominantly male, about a third identified as First Nations, and their largest sort of middle age at 36 was the average age. Unfortunately, because of the anonymity that's sort of included in on-site drug checking, we don't have any demographic information available for that control group. When we look at the location or timing of use, so they were used in a variety of settings. So these fentanyl test strips, we know that they were primarily used in those high-risk settings. So 55% of people use them at home, which is a location where obviously we want to try to intervene with harm reduction interventions, given that's where the majority of individuals are passing away. And many individuals use them on the alley or the street. Notably, about 80% of people used the test strips before using the actual substance, but that wasn't the only way that individuals were using them. When we look at our primary outcomes, so we're looking at the fentanyl positivity of opioids. So samples are identified by opioids by the participant. We were looking at the fentanyl positivity of those samples that were tested by individuals themselves using take-home drug checking, and then comparing that to, during the same time period, all opioid samples tested across the same sites used by technicians using on-site drug checking, with fentanyl test strips as well. We can see that our predefined equivalence limit was approximately 5%, and that's what the study was powered to check. And we can see that they're equivalent, that there's only a small difference between the findings, and that the confidence intervals are significant for this particular finding, suggesting that the fentanyl positivity opioids tested using take-home drug checking was equivalent to that of on-site drug checking. When we look at stimulants, we see a bit more of a divergent picture. I should say that our study was not powered to find a statistically significant difference between stimulant samples, but you can see that in both cocaine and crystal methamphetamine, that take-home drug checking was associated with much higher rates of fentanyl positivity. One of the postulated reasons for this is that both crystal meth and other stimulants can produce a false positive if they're not diluted enough with immunoassay test strips such as fentanyl test strips. To test this theory, we stratified individuals who were experienced with fentanyl test strips and who were using them for the first time. This chart is again using the same substance use categories, but is the numbers are the difference between the fentanyl positivity of take-home drug checking versus on-site drug checking. We can see that in the left group, so those who are inexperienced with using fentanyl test strips, that there's more of a divergence between the technician tested on-site drug checking versus the ones that are being tested at home. And as you can see, when individuals became more experienced with using fentanyl test strips and perhaps became more cognizant of the appropriate dilution needed that were provided on the instructions, that they had a result that was closer to what we'd expect as sort of the gold standard of on-site drug checking. When we asked individuals about behavior change, so if your drugs tested positive for fentanyl, what would you do? We allowed them to sort of say that they wouldn't change their behavior, that they would exhibit what we would consider positive behavior change, so using less or slowly, having someone check on them, or using at a space where they could receive naloxone if required, or using what we would consider sort of in a negative way, so using alone or using more quickly. We see that when we ask this question, the majority of individuals reported no behavior change, which may be expected given that our fentanyl positivity rate of our drug supply is upwards of 90%. And so that may be everything that people are exposed to or expecting. But when we look at the individuals who did report behavior change, that it was largely positive behavior. So sorry, I'm just going to show the slide again, but this is only the individuals who are reporting a behavior change that the overwhelming majority reported something else positive. And so even though the fentanyl is quite pervasive in our drug supply, the individuals are still reporting great behavior change, or positive behavior change, I should say. When we asked individuals of the sort of acceptability, so the overwhelming majority said they would use the fentanyl test strips again. They felt confident in their ability to interpret the fentanyl test strips, and that the instructions that were provided, which was essentially a short sort of information provided along with the kit, that their instructions were easy to follow. So from this, we can say that the take-home drug checking results for opioids were felt to be equivalent to results obtained through on-site drug checking over the same period of time. We know that participants in our study felt that fentanyl test strips were easy to use and they were interested in using them again. And that take-home drug checking, so the distribution of fentanyl test strips, may be a valuable addition to existing harm reduction efforts in order to mitigate the risk of overdose. Some of the limitations of our study was that it was primarily a pilot program, and that there were some things that we would have liked to have that we were unable to collect in order to preserve the utility of existing harm reduction services. So we don't have demographic information available for individuals for completing on-site drug checking. We're not directly comparing one sample using both methods. So ideally, we would have taken a sample and had it tested on site and then the rest of it tested at home. But pragmatically, that was just impossible. So we're assuming that the drug environment in these settings is the same by using the same sites in the same period of time. We also, much of the information they were collecting was based on self-reported drug categories. So what individual thought a substance was, and then that there were self-reported test results as well. I'd like to thank everyone involved with the project and anyone here in BC who's helping to continue this work forward with the ongoing distribution of fentanyl test strips. Thank you very much.